Could you just clarify for us, what is a CTPA?
So a CTPA is a CT scan, which where we introduce contrast into a patient, and it allows us to visualize the vasculature of the lungs, and that allows us then to identify whether there are defects in the perfusion, so that we can then diagnose a PE in a patient. CTPA stands for computed tomography pulmonary angiogram.
So is it the case that low-risk PEs were just not noticed in the past?
Yeah, absolutely. And as I mentioned earlier, well, due to the way they're presented, that there often we see a lot of patients may initially be diagnosed with things like pneumonias, lower respiratory tract infections, and actually the thing that makes people think that it is a PE is the fact that we haven't seen any clinical improvement despite them being on antibiotics. Or likewise, it's just that the patient has risk factors for a PE, so the clinician initially seeing them feels that they can't rule out a PE, so they're sent up for that purpose as well. But interestingly as well, what we've seen over recent years is, because of advances in diagnostic tools like CTPA, what we've seen is that actually the number of PE diagnoses have gone up. But linked to what I was saying earlier, what we've seen is mortality has actually decreased over time. What we feel is that actually, because of the sensitivity of CTPA and improved sensitivity of older imaging, like VQ scans, we're actually able to pick up now, what we're actually seeing is a lot more of these lower risk PEs being picked up, which is why it's a very different scenario maybe to what you would have seen 15, 20 years ago, where you were largely picking up the higher risk PEs.
And has CTPA now replaced ventilation perfusion scanning?
Yeah, so as the primary diagnostic modality, that is now the first line. There are certain groups where it may still be used, so that there have been concerns in the past with exposure to radiation for certain groups, younger patients, for example. But actually now CTPA is almost exclusively used. And as I mentioned, that would be our first line diagnostic modality now in PE.
So what were the problems, and why did you feel the need to get involved?
Prior to us developing the service, it was felt that there wasn't a consistent approach within the health board towards management of PEs. And what I mean by that is we did some work with DVT follow-up, and we found that prior to our service being implemented, 50% of patients weren't having any sort of follow-up following the diagnosis. And follow-up's important because, number one, we need to see how patients are recovering, but also we need to make decisions around long-term management. And linked to this, there was also an NC pod report in 2019, which looked at the current status of PE management within the UK. And again, that flagged up some key issues around both the follow-up aspects, in terms of the fact that it was felt that patients weren't being followed up correctly, but also a lot of other things that made us think about our service, which were based around that acute management. And what they flagged up was that there was no assessment of severity being used in a lot of cases for PE at the point of diagnosis. That was felt that actually many of the low-risk PEs that we've discussed so far actually would have been appropriate for ambulation, but weren't being ambulated. So it was estimated that at the time, about 37 to 49% of PEs could actually effectively be ambulated. But from the report, they found that on average in the UK, it was only around about 16.4% who were actually ambulated. So again, showing that actually there are patients who don't need to be in hospital, but were. And there's other aspects to it as well in relation to, for example, how we discharge patients and the information that we give patients, because it's critical that when we discharge a patient from hospital with a PE, they are aware of what a bad outcome can look like, or what a complication can look like, and that they can have access to get immediately back into hospital. So things like understand patient education, but also understand the things like patient social backgrounds, access to transport, do they have good family support? Those are all critical components of having an outpatient PE service. And these were things which, in line with what was found with that report in 2019, we didn't feel that we were locally addressing. And then the BTS, the British Thoracic Society Quality Standards, came out in 2020, which effectively said we should be doing all of these things. We used that then as a prompt to look at our PE services, and then use that as a catalyst to develop the service that we developed.